neonatal resuscitation. Now guys, normally whenever we do a resuscitation with respect to adults, you hear about ABC. In case of trauma, in case of surgery, we hear about whenever there's a trauma is there, then always see first the cervical spine and stuff like that, right? As you know, I talked about hypothermia first. Why? Because in case of newborns, temperature is a very important factor. That is why in case of resuscitation also, during the entire procedure, TABC is there. Okay, if they ask you in neonatal, options are there, you have to mark TABC. T stands for temperature, A stands for airway, B stands for breathing, and C stands for circulation. Remember this order, TABC. Alright. Now see, during your initial assessment, you found out that the baby is not crying. So what are you going to do? First thing is temperature maintenance. How are you going to put temperature? Is put the baby in the warmer. Okay, how remember what was the mode of action of warmer, guys? Radiation. Okay. Now first was you put them in the warmer. Second is airway. Now if see, I'm saying, okay, if there is secretion, you do suctioning. Otherwise it is not required. What you have to do is you just slightly extend the head of the neck like a rose position, so that the airway, it comes in a line. Okay. Then is breathing. How do you activate somehow or stimulate the breathing? Is by tactile stimulation. Now tactile stimulation can be done in two ways. One is by back rubs. Okay. Other one is by flicking the toes. Okay? Not by spanking the butt. I asked my HOD that time. वो पता नहीं किस बात के लिए offend हो गए थे. Anyway, after initial steps, guys. Okay, so we've done the TAB, temperature, airway, and breathing. So first, what you did was you kept the patient in the warmer. A is going to be airway. Put the head up. B is breathing. That is going to be by how? By tapping the back or by flicking the soles. Even after this, if the baby is not breathing, now you have to start thinking, okay, now the resuscitation has to start. Now guys, normal heart rate in general will say anything more than 100. That's why in Apgar also we gave it as a 2. But in any conditions, if the heart rate is reduced in a newborn, mostly we can again think about what condition, guys? Birth, asphyxia, because there is hypoxia. Okay. So if the heart rate is low, now because see we did temperature, then we did airway, then we did breathing. Now next is C, that is circulation, guys. Now in circulation, guys, if you find out that the heart rate is less than 100, now we have to start giving the baby oxygen because the cause is hypoxia. And how do you start this? By giving PPV. Guys, what is the full form of PPV? It is positive pressure ventilation. Okay? Now positive pressure ventilation can be done by two methods. One is bag and mask. Okay. Other one is endotracheal intubation. Correct? Now when you're doing this bag and mask and endotracheal intubation, another question which they can ask is how much is the oxygen concentration? So guys, if the baby is a term baby or a late preterm, that time you will give the normal room air, that is 21% oxygen. If the baby is early preterm, okay, less than 34 or something less, that time you have to give the concentration as 30% oxygen. I have written it over here. Starting at, okay, normal term and late, you have to give 21. Otherwise, early preterm, you have to give 30%. Now again, you're doing positive pressure ventilation. If the baby starts responding, if you see the heart rate is improving, good to go. Now, if you see there is no response to the PPV, next what we are going to do is again check the heart rate, guys. First, when we check the heart rate, when it was less than 100, we gave PPV. Now again we check the heart rate and we found out, guys, that the heart rate is now less than 60. We are now more tensed. Now is the time when you are going to start. What is CC, guys? This is chest compression plus ventilation. Not only chest compression alone, you have to give chest compression and ventilation. They will ask you the ratio, guys. The ratio is 3:1. Okay, You gave, for example, if they will say maybe 3:1 will be there, okay? So then if it is 30, so it will be 90:30 like that, right? So 3:1 is the ratio of chest compression and ventilation. When are you going to do it? When the heart rate is less than 60. Now guys, even if after the, and how are you going to do chest compression? Usually you can do with a single a thumb also will be there, or you can use the both ways over here like this. You can do it, okay, towards the chest over here. Now guys, even after this, if it is not working, if there is no response, now comes our brother injection, that is going to be adrenaline. Guys, the route, now this is very important, many people don't know this. This can come is going to be via umbilical vein, okay. The dose is going to be 1:10,000, okay. And in injection, how much are you going to give? 0.2 ml per kilogram of the baby. What did I say? First thing is we tried temperature, then we did airway, then we did breathing, then we did circulation. In circulation, what we checked, guys, if the heart rate was less than 100, we gave ppv. Even if it still did not respond, we checked the heart rate again. If it was less than 60, we gave chest compressions and ventilation with the ratio of 3:1. And even after this, we found out that there was no improvement. Then we gave injection adrenaline. What was the dose? 1:10,000, 0.2 ml per kilogram. Route was via the umbilical vein, and we gave adrenaline. That is your neonatal resuscitation in a nutshell. Okay, initial assessment, we found out then the baby is crying. Initial action was temperature warmer, airway extension, breathing was tactile stimulation. Assessing the heart rate and respiratory rate, less than 100, we gave ppv. Then we found that this heart rate is less than 60, we gave chest compression with ventilation at the ratio of 3:1. Even if no response, we gave adrenaline. Dose is 1:10,000. Route is via the umbilical vein, and dose was 0.2 ml per kilogram. Good to go, guys. Next, guys, let's talk about neonatal disorders. Talking about a superficial one, I know most of you are already able to diagnose this. Even if you are not able to diagnose this, now you will be able to diagnose. Guys, this is known as ophthalmia neonatorum. Again, if my handwriting is bad, or if my spellings are not that correct, please excuse me for that, but rest logics are good, okay. The most common cause is going to be chlamydia trachomatis, okay, over Neisseria gonorrhea. So the most common cause is chlamydia trachomatis, and second most common is going to be Neisseria gonorrhea. What is the prophylaxis, guys? Prophylaxis is if you give erythromycin eye drops. So now guys, tell me on the comments right now, whenever you're watching this video, if you take erythromycin during the pregnancy, there is one condition. What happens? You have 5 seconds, okay? Again, I'm going to repeat. If you take erythromycin during pregnancy, what is the abnormality a baby suffers? 5, 4, 3, 2, 1. The answer is, nowadays it is called as idiopathic, or you can say hypertrophic pyloric stenosis. Idiopathic hypertrophic pyloric stenosis. When you use erythromycin during pregnancy. We'll talk more about that later. Okay, so erythromycin, if you use, you say, that's why we don't use it even nowadays. That erythromycin causes idiopathic hypertrophic pyloric stenosis. Next, guys, let's talk about the systemic infections, sepsis. The problem with sepsis, guys, is there are very vague features, like dull baby, not feeding, sick baby. Basically, what I want to say is sick baby. Okay, sick baby. So any sick baby is there, unless proven, treat as sepsis. Okay, basically sepsis ka features are very vague, like low appetite, very lethargic, or fever and sick like that. So treat it as sepsis. So guys, the most common etiology is bacterial over virus. In India, the most common cause is Klebsiella. Worldwide, the most common cause is, what is this, guys? Group B strep infection worldwide. In India, the most common cause is going to be Klebsiella, but worldwide it is going to be Group B streptococcal infection. The best investigation, guys, is going to be blood culture. Hana? What are the inflammatory markers, guys? ESR, erythrocyte sedimentation rate, or C, reactive protein will be elevated. What is your management, guys? We are going to be giving empirical antibiotics. What is the meaning of empirical antibiotics, guys? Empirical antibiotics means without any proper confirmed diagnosis, we are going to start the antibiotics. Simple. For gram positive, we are going to give penicillin. And for gram negative, we are going to give amino glycosides. Okay, so that is your empirical antibiotic, and that is your treatment for sepsis. Next topic, guys. Let's talk about respiratory distress. I hope you guys are enjoying. Okay, so in respiratory distress, in case of baby up to 2 months, we will be defining as when the respiratory rate is more than 60. Along with that, if you have any retractions, maybe it can be intercostal, maybe it can be subcostal, maybe it can be supraclavicular, maybe it can be above the sternal notch. Any retractions, that is also a sign of distress. In case of severe conditions, if you see cyanosis, central cyanosis, and even grunting which will be there, that is also the signs of respiratory distress. Now let's talk about, guys, what are the normal causes of respiratory distress in a baby. We are going to divide it into two parts. One is going to be in term, and other one is going to be in preterm. In a term baby, the most common cause of respiratory distress is going to be TTP. Okay, TTNB, and the full form is, come on, transient tachypnea of newborn. Transient tachypnea of the newborn. Okay, what is the cause of transient tachypnea of the newborn, guys? In the history, you will have the question is term baby. First of all, term baby born via lower segment cesarean section. I'll tell you why. See, whenever there is normal delivery, guys, you guys know that the mother is applying some pressure, and then the pelvic muscles also are there, it's somehow pressing to the baby. So because of this squeezing like action, the fluid inside the lungs comes out. But now in a LSCS condition, there is no such pressure. Apne aap, we are carrying the baby and pulling it out, so there is no such squeezing pressure sometimes. So that is why the fluid it gets retained in the lungs. That is why, guys, this TTNB, right, TTNB is also known as wet lung syndrome. But the best part is management is only symptomatic. Everything will be all right. Symptomatic treatment. All right. Now over here, guys, you have to see the X-ray here of TTNB. Here what happens is the fluid gets collected in the perilobar fissures. Okay, I'll remove this. See this. Over here you can see there is like it's marked with the arrow. There is perilobar fissure. Fluids are getting filled. Okay. Next thing what you have to see is that, like, if you see a sun, it's like this. There is a sunburst like this. So over here also, guys, you can see this picture over here. There is like sun bursting over here. So that is why, okay, there is two things. Perilobar fissure gets fluid filled, and then there is sunburst appearance over here. So now I want you guys to comment below, where do you see sunburst appearance in osteology? In case of bone tumors, mark it and comment below, okay? Because we have to study integratedly. So tell me, where do you see it? Okay. Next, guys, we are going to talk about where do you see respiratory distress in a preterm, guys. The most common condition is RDS, also known as HMD. RDS stands for respiratory distress syndrome, while as HMD stands for not hand mouth disease, it is hyaline membrane disease. Okay, So respiratory distress syndrome or hyaline membrane disease, why this happens? It is because of lack or non-functional surfactant. Okay, lack or no functional surfactant. Remember guys, surfactant production starts by 34 weeks of gestation. Surfactant production starts by 34 weeks of gestation. So any preterm who is less than 34 weeks can have a risk of RDS or HMD. Now what you see, a classic picture over here in an RDS is this. Look, see, usually air is black in color, right? Now because over here you can see there is white full, so this is known as, you see, white out. It will be there. Okay, so then a white out or ground glass appearance will be there. And in case of severe RDS, we have to give surfactants. And how are we going to give surfactants? That is going to be via endotracheal way. How do you prevent RDS, guys? Is when you give steroids, corticosteroids will be given. Two methods you can give is, one is going to be by giving betamethasone, another one is going to be by dexamethasone. Now beta means 2, so we'll give it 2 times, that is 12 milligram will be given 24 hours apart, that also 2 times. Dexa we will be giving 6 milligram 12 hours apart 4 times. At the end the value is same but the different numbers. So remember how I remember this, beta means 2, so 12 milligram 24 hours apart 2 times. Dexa will be 6 milligram, 4 doses will be given 12 hours apart. These are times any doses. Another condition with respiratory distress in babies which will be there is congenital diaphragmatic hernia. In congenital diaphragmatic hernia, guys, you can see over here in the X-ray, you will see that there is bowel loops in the lungs. And the other thing you can see over here is there is, like, see over here there is a diaphragm, like a, marking over here, but there is no diaphragm marking over here. There is no diaphragm marking, Hana? Correct? Now let's talk about it in detail, guys. In congenital diaphragmatic hernia, because of the all the intestinal structures going inside the thorax, the lungs will get compressed. You will not be, the baby will not be able to breathe properly, and there will be pulmonary hypoplasia. Now there are 2 types of congenital diaphragmatic hernia. The most common type of CDH is going to be known as Bokdalic hernia, and the other one is Morgagnian hernia. Now the issue with this thing is, right, they are asking the position also with this. So here is a mnemonic, like how we have Indian Premier League, Bangladesh has BPL, Bangladesh Premier League. So remember this by that way. Bokdalic is posterior in location in the left side. So left, posterior, lateral will be there, even lateral also, L will be left and lateral as well. Okay, so remember Bokdalic as BPL, Bokdalic posterior left. Okay, Morgagnian, you have to remember Ram, my friend was Ram. So R, which will be there, is the right side, R is right side, A is anterior, and M is medial. Okay, so Morgagnian hernia which will be there, okay, that is going to be Ram, remember the mnemonic, and Bokdalic is going to be BPL. In the question, guys, they'll ask you is, patient was diagnosed with a respiratory distress. We found out that there is congenital diaphragmatic hernia. What is the contracting method of PPV? That is, you will not do bag and mask ventilation. Why? When you do bag and mask ventilation, guys, there is some amount of air which will be going through the esophagus into the stomach. Then it will go to the intestines, and now already the intestinal content is already there in the thorax. So then the intestine gets dilated and it will further cause pulmonary hypoplasia. That is why, guys, bag and mask is contraindicated in congenital diaphragmatic hernia. Last topic for this video, or I don't know if this is the other 4th part. Okay, but see, neonatal jaundice, guys. Now neonatal jaundice, let's talk about how jaundice happens. Blood from the RBCs. RBC is broken down into heme and globin. Now guys, we'll study this in biochemistry, but heme which further gets broken down into biliverdin, which is green in color, and then it gets broken down into bilirubin, which is yellow in color. So fast forwarding, heme gets converted into bilirubin. Now bilirubin which is converted, it is unconjugated. Guys, unconjugated basically means it is water insoluble. Now because it is water insoluble, it is lipid soluble. Remember this, okay? I'll tell you this later why. So it is ulta, right? So it is water insoluble, because of which it cannot be excreted, but it is lipid soluble. We need an enzyme to convert this unconjugated bilirubin into conjugated bilirubin, and that enzyme is, guys, UDP glucuronyl transferase. That enzyme is UDP glucuronyl transferase. Once it is conjugated bilirubin. With the help of our bile duct, it goes into the second part of the small intestine, and from there up to 90% is in the form of stercobilinogen. That is why feces is yellow to dark in color. 10% is urobilinogen, that will be in the urine. Okay guys, now let us imagine there is some, now this logic, this same pathophysiology is same for adults as well. Just imagine if there is some issue over here. Conjugation could not take place. Conjugation could not take place. That's why there was a build-up of unconjugated. Maybe there was an obstruction over there. Now, because of which it is now not able to transfer into the small intestine. It gets transferred into the blood. And you know, guys, blood is filtered with the help of kidney. And this all bilirubin now will go into the urine. Earlier which 10% was there, now almost everything will go into the urine, and then there is nothing in the stool. So that's why you will see clay color, straw colored, pale color stools over there, and bright yellow color urine will be there in case of any abnormality. This is the example. Talking about now assessment of jaundice, guys. You assess jaundice based on the serum bilirubin. Serum bilirubin in the LFT reports are of three types. One is going to be total, one is going to be direct, and other one is going to be indirect. Guys, direct is representing your conjugated type of bilirubin with the help of UDP glucose, which we are transferring unconjugated into conjugated, right? Conjugated is referred with the help of direct. Indirect bilirubin is referred with the help of unconjugated bilirubin. Indirect, unconjugated, direct, conjugated. Simple. Normally, the total value of bilirubin is going to be 1 milligram per deciliter. Indirect is 0.9 and direct is 0.1. In adults, when you see jaundice in the sclera, that is usually around 2 ml. But now we are talking about visual assessment in newborn. Guys, in newborn, you have a rule, that is the Kramer's rule, based on assessment of color from top to bottom. Okay, it is cephalocaudal in nature. What you have to remember is this only applies to unconjugated bilirubin. Now unconjugated bilirubin is indirect. Correct? Now what happens is the first part, which is to get eyes, as I said, it is cephalocaudal impression. First will be your eyes. In babies, it is going to be 5 milligram per deciliter. Okay? The last one to spread is going to be in the periphery, that is the palm or soles. This is very dangerous. It is going to be more than 15 milligram per deciliter. Now it is so much more, and it is unconjugated. Remember what I told you about unconjugated? It is water insoluble, but it is lipid soluble. Because of this increased amount, it can pass the blood-brain barrier. It can pass the blood-brain barrier. It can go and affect the basal ganglia, and it can cause a condition known as, come on guys, tell, kernicterus. Okay, you'll have chorea-like symptoms, you'll have much more abnormalities. It affects the IQ, so then it basically affects the baby's brain. It affects the basal ganglia. If it is more than 15 milligram per deciliter, a dangerous condition. Now let's talk about neonatal jaundice. Neonatal jaundice, guys, can be of two types. One is your physiological, which is the most common, and one will be your pathological, which is pathological. Now, what are the causes of physiological jaundice? How do you first say what is physiological jaundice? Physiological jaundice is when the onset is after 24 hours, not within. Only after 1 day of birth, after 24 hours, the duration will be less than 2 weeks, and area involved is never palm and soles. Never palm and soles. Okay, what I said, onset after 24 hours, duration less than 2 weeks, area is never palms and soles. What can be the reason, guys? One thing is, guys, you know that fetal RBC का lifespan जो होता है, that is less than around or equal to 90 days. Adult में, guys, कितना होता है? ये भी comment कर दो. Adult में RBC का lifespan क्या है? It is a PYQ also. Okay, so fetal RBC have a shorter lifespan, that is less than 90 days. That is why, because again it dies fast, hemolysis will be there. Again, the same process of jaundice which I explained you will be there. So that is why you're having this. Second condition is if the baby is not still growing, right? So what if there is an immature UDP gluconeal transferase? It will get mature. So but now, you know, just now it is born. So give it some time here, Hana? So that's why it will be one physiological causes, immature one. So one is their fetal RBC if it is dying first. Second is immature UDP. Third will be, what if there is already so much fetal RBC? In case of maybe, you know, what if a large for gestational age baby is there, anyway more blood is there. So that's why this is happening. These are all physiological conditions. Let's talk about pathological condition, guys. In pathological conditions, you have to now divide it into two parts. One will be unconjugated or indirect, right, bilirubin, and one will be your conjugated causes. Let's talk about conjugated causes. Guys, the etiology in conjugated causes will be mostly, if you see, is hemolysis. Now hemolysis will be there, okay, why? Because of increased RBCs will be there, that is your polycythemia. In neonates, it is more than 22 grams per deciliter. Okay, hemolytic disorders, one is your inherited types. Inherited, you have to remember, guys, G6PD. G6PD. Acquired will be if there is any incompatibility like ABO or RH incompatibility. Okay, then what if there is an issue with UDP gluconeal transferase? Because, guys, UDP is the one which is converting unconjugated into conjugated. So if UDP is kharab, the unconjugated bilirubin will be increasing. That is pathological type. So in UDP gluconeal transferase, you have to remember something which is known as Crigler-Najjar syndrome. There is two types of Crigler-Najjar: Crigler-Najjar type 1 and Crigler-Najjar type 2. In type 1, guys, UDP gluconeal transferase is completely absent. So very dangerous. While type 2, UDP gluconeal transferase is decreased. Means it is there, but it is less. This is your unconjugated causes. Let's talk about your conjugated causes. Guys, the most common cause of a conjugated cause is due to obstruction. And the exception is because of extrahepatic biliary atresia. Extrahepatic biliary atresia, there is a block, so obviously it will not go. Conjugated ही बढ़ता रहेगा, फिर convert तो हो रहा है, UDP काम कर रहा है, but then there is no passagely, then how it will work? In clinically, what you will see, as I said you, now it is not going to the intestine, everything will go and filter into the kidney. So the stool will be pale, straw colored, Hana? There will be no color, and urine will be bright yellow. चलो इसको yellow ही कर देते हैं. Yellow in color, bright yellow in color. Other causes of conjugated, okay, we're talking about of conjugated pathological jaundice, see conjugated type here, na, is Dubin-Johnson syndrome. Another one is Rotar syndrome. Okay. What is the treatment, guys? It is phototherapy. Okay? What is there in phototherapy, guys? We are converting this bilirubin into something now, because this bilirubin which we're talking about is water insoluble, right? We're not able to convert it. So bilirubin we're converting into something which is water soluble, that is by light. Remember, light luminous, so it is lumirubin. Now, guys, this is water soluble, and then, guys, this is excreted. Okay, if phototherapy is not working. Now, guys, if phototherapy is an option, then another option you have is exchange transfusion. There is a donor we'll take the donor blood to the baby and we'll remove all the baby blood out. That is exchange transfusion. Last topic for today, guys, is Gilbert syndrome. Guys, Gilbert syndrome is similar to Crigler-Najjar type 2, but Crigler-Najjar type 2 is seen in newborn. Gilbert syndrome is something which is seen in older children or in adolescent. What is adolescent age group, guys? 10 to 19 years of age. Alright. The defect is again decreased UDP gluconyl transferase. It is a benign condition. It comes with intermittent jaundice, which is exaggerated during exercise or stress. So the question can come is, a player was there who was, playing football or something, and after every match or something, or after regularly playing, he gets sick, he gets jaundice. So that is Gilbert syndrome. Management again is symptomatic, reassurance is there, nothing to do about it. Okay. So guys, we're done with this topic for now. I want to, every day I will give some quote which will be there. So this today for today is, the future depends on what you do today, guys. Push yourself harder. No one is going to do it for you. You do you. What I'm trying to say you guys is, look, there are so many sources here. There is so many things. There is so much you can do also. Why do you think there are so many apps still? Why no one is why not 1,000 people are topping? Because it is you yourself. And trust me, guys, if I was able to do it, right, you are definitely able to do it. And trust me, I'm telling you, I'm not telling you just to, so that you will get, fake hopes. No, you came till this video, till this end, means you had something to do. It means you have a goal set in mind. Always remember that goals, right? And every day, as I told you before, like starting this exam, starting your topic, please read this and then start your day. Okay. It is done for me for this video. Take care, guys. See you in the next video. Bye-bye.